Hello everybody. Today we are going to discuss the case of acute kidney injury. So we have this 69-year-old gentleman who is a known case of only varicose vein, no comorbidities. He came to us with the chief complaint of pedal edema since 1 month, a generalized weakness since 1 week, cough since 2 days, breathing difficulty since 1 day. On examination, pulse rate was 112 beats per minute, blood pressure 114 by 78, respiratory rate 20, saturation 99, bilateral pedal edema present, and the palar was present. So on examination, CVS S1, S2 present, respiration, bilateral crepitation were present, abdomen was soft and non-tender, CNS patient was conscious oriented. So these are the investigation of this patient. As we can see, his creat levels were 11, and surprisingly the patient was not having any comorbidity. He was not diagnosed with anything, and he presented to us with the only bilateral pedal edema, and suddenly his creat came up to 11. So we have immediately we have taken the decision to dialyze him, and we have given nephro consultation, uh, and we have sent the investigation to diagnose the cause of acute kidney injury. Before that, we did USG abdo-pelvis, which showed bilateral kidneys are bulky with raised echogenicity. Bilateral perinephric fat standing were present. Then minimum free fluid were there in abdomen and pelvis. Liver, gallbladder, pancreas, spleen were normal. And to find out what is exactly the cause of this acute kidney injury, we have seen the number of investigation, which includes the serum electrophoresis, free light chain assay, ANA, C3, C4 complement, C Anka, P Anka, calcium phosphorus uric acid, and renal biopsy. The blood report of the serum protein electrophoresis showed presence of the M band. As we can see, the serum, this is the protein composition of this patient. So, and the biopsy report revealed the light microscopy and the immunofluorescence finding favors the diagnosis of light chain cast nephropathy. Since free lights were very high, so the final impression of this patient was multiple myeloma, and we were dialyzing this patient, and we were managed this AKI part, and patient was stabilized after few days. We shifted this patient to the ward. In ward also he was very extremely uremic, restless, and in one day he went to the tumor lysis syndrome, started on hydration. This on After few days, this patient had one episode of GTCS, and he shifted back to the ICU. At that time, this sodium level was 119. So CT brain done to rule out any intracranial pathologies there or not. So this is the screening MRI of this patient, which showed no acute infarct, hemorrhage, edema, mass effect, bilateral frontal subdural collection measuring up to 13 mm depth, patchy narrow signal alterations. This is the 2D echo of this patient, which showed normal ejection fraction and no RWA. So, in view of multiple myeloma, we have started this patient on DEXA and the bortezomib. Thank you. We'll discuss how to manage this acute kidney injury, this types and the type of the acute kidney injury in the subsequent slides. So we'll see what is acute kidney injury, what are the diagnostic criteria and types. So sudden disruption of the previously normal or stable kidney function, usually occurring over hours or days, is termed as acute kidney injury. AKI is often diagnosed when the patient develops an elevation in blood urea nitrogen and serum creatinine. These changes typically results from decline of glomerular filtration rate, AKI case may reflect increased urea or creatinine production without any reduction in GFR. AKI can occur prior to significant increase of creatinine levels. This is especially true for ICU setting where frequent administration of large volume of intravenous fluid can dilute serum creatinine. Classification of AKI based not only on the serum creatinine but also on the degree of urinary output reduction and the requirement for renal replacement therapy. So the classification of AKI is done by the two classification, that is rifle criteria and acute kidney injury network and kidney disease. In short, we are calling it as KDGO. So we'll see what is the rifle criteria. Rifle criteria is divided into the 5 subtypes, that is risk. Risk is R stands for risk, and and the risk defined as increase in creat level 1.5 times above baseline or decline in the GFR more than 25%. Less than 0.3 ml per kg per hour for 24 hours. And the failure defined as rise in creatinine more than 3 times above baseline, or create more than 4 mg per dl, or decline in the GFR more than 75%. Urine output criteria for same zero point 0.5 to 1.9 above baseline within 7 days, or at least 0.3 mg per dl increase in 48-hour period. And urine output criteria less than 0.5 ml per kg per hour for at least 6 hours. Stage and as increase in creatinine 2 to 2.9 times above baseline, and the urine output criteria less than 0.5 ml per kg per hour for at least 12 hours. Then stage 3 is defined as rise in creatinine 3 times above baseline, creat of at least 4 mg or initiation of dialysis. Urine output criteria less than 0.3 ml per kg per hour for at least 24 hours. Now, there are certain situations where only blood urea nitrogen and serum creat levels are high without actual reduction into the GFR rate. So, what are these conditions? These are increased biosynthesis of urea, which occurred into the bleeding in case of medications like corticosteroid tetracycline, increased protein intake, amino acid administration, hypercatabolism or febrile illness, increased biosynthesis of creatinine, then increased release of creatinine from muscle, drug interference with tubular creatinine secretions. For example, in case of cimetidine, dronedarone, and trimethoprim, then spuriously elevated creatinine calorimetric assay as occurred in ketoacidosis and cephalosporin. Now we'll see what is pathogenesis. Pathogenesis of AKI is quite complex since it has multiple etiologies and risk factors, which is more anatomical in nature. However, the immune mechanism play vital role in the injury and regulation of inflammatory response and in the repair of epithelial layer. There are some differences in the mechanism of AKI depending on etiology causing AKI. So, the basic etiology is renal ischemia. It is a primary modality of acute kidney injury, and it can be due to various mechanisms such as production of oxygen-free radicals, cytokines, and enzymes, endothelial active leukocyte adhesions, activation of coagulation, and initiation of apoptosis. Common understanding is that the decreased renal perfusion from any cause leads to reduction in GFR, whereas renal ischemia and disease of glomerulus and tubule may be responsible for intrinsic renal failure. So the renal perfusion is extremely well regulated by afferent and efferent arterioles that maintains constant blood flow and filtration fraction within the range of mean arterial pressure of 80 to 180 mmHg. The tubulo-glomerular feedback mechanism operates through macula densa, renin-angiotensin-aldosterone system, and the myogenic activity of afferent arterioles are the mainstay of autoregulation mechanism of renal blood flow. So, in response to hypotension and to maintain the glomerular filtration, the afferent arterial vasodilation occurs from the secretion of vasodilators such as prostaglandin and nitric oxide and stimulation of renin-angiotensin-aldosterone system. So, during hypertension, the afferent arterial vasoconstriction occurs due to various mediators such as endothelin 1, angiotensin 2, thromboxane A2, prostaglandin H2, leukotriene, adenosine, and sympathetic nerve stimulation, along with efferent arterial dilation to stabilize the renal blood flow and GFR. So the risk of acute kidney injury increases when these autoregulatory mechanisms are inhibited by mechanisms such as use of angiotensin converting enzyme inhibitor and non-steroidal anti-inflammatory drugs. So the acute kidney injury is commonly seen with hypotension, secondary to hemorrhage, fluid loss, sepsis, poor cardiac function, and the use of vasoactive drugs. The kidney normally receive approximately 25% of cardiac output. And the kidney has peculiar arrangement of glomerular afferent and efferent arterioles branching into peritubular arteries, vasa recta, which are the vital for reabsorptive function. So reabsorptive function is highly energy dependent function. The adenosine triphosphate production that occurs within the cortex is by oxidative metabolism, whereas in the medulla, nearly 33% of energy comes from glycolysis, which makes it susceptible to ischemia. The partial pressure of oxygen drops from 70 mmHg in the cortex to 20 mmHg in medulla with high oxygen demand from tubular saltwater reabsorption function. Both of these functions make medulla very sensitive to hypoxia and injury. The tubular ischemic injury and necrosis leads to disruption of the tight junction between the cell, allow back leak of glomerular filtrate, and further depressing effective GFR. The proximal tubule are more vulnerable to mitochondrial dysfunction as they depend on the aerobic metabolism in comparison with the distal tubular cell, which can use glycolysis for metabolism. Other suggested mechanism of tubular injury are endothelial cell activation, endothelial swelling, upregulation of adhesion molecules with denuding glycocalyx. In addition, there is leukocyte activation, platelet aggregation, red cell trapping, activation of the coagulation pathway, which leads to vascular congestion and further ischemic injury. The dying cells slough off with the shedding the cellular debris into the tubule, forming obstructive cast, which further decrease GFR and lead to loss of functional nephron. Induced autophagy has also been proposed as the mechanism of tubular injury. Ischemia reperfusion hypothesis suggests that ischemic injury leads to the loss of polarity of epithelial cells with alteration in the location of adhesion molecule, sodium potassium ATPase, and subsequent cell death, either by necrosis or apoptosis. Due to this alteration in the location of adhesion molecule, the viable epithelial cell fail to effectively adhere to basement membrane and eventually fail in their repair process. So some investigators suggest that when injury is severe and prolonged, epithelial cell may transfer to fibroblast and lead to repair by fibrosis. Now we'll see what are the causes of acute kidney injury. The causes of acute kidney injury is divided into prerenal azotemia, intrinsic renal disease, and postrenal failure. So when glomerular perfusion is threatened, autoregulatory mechanism help maintain glomerular capillary pressure. If autoregulatory mechanisms are inoperative, a given reduction in renal blood flow provokes sharper decline in GFR. Use of NSAIDs in patient with the renal hypoperfusion, for example, can lead to severe AKI. Administration of angiotensin converting inhibitor in patient whose renal blood flow is obstructed by bilateral renovascular artery stenosis can cause severe azotemia. Now we'll see mechanism of high blood urea creatinine ratio in prerenal failure. Reduce renal perfusion, slow down the flow of filtrate to renal tubule, enhancing reabsorption of the urea. Because creatinine is not reabsorbed into the renal tubule, its clearance is unaffected by the nephronal factors. So the clearance of the urea is reduced proportional to that of the creatinine. Explaining usually high BUN creatinine ratio that is seen in prerenal states. In such a situation, the blood urea nitrogen and the creatinine ratio typically exceeds 20 to 1, 20 to 1. The hallmark of pre-renal condition is the intense renal conservation of salt and water as reflected into the urine composition, which shows the low sodium concentration and the fractional excretion of the sodium is less than 1 and high osmolarity. So we'll see the high urinary sodium in the prerenal cases. So the coexisting abnormality of the tubular function, the effect of diuretic, sometimes the effect of diuretics, and the presence of non-absorbable anion substances in the urine, such as bicarbonate in patient with the metabolic alkalosis, certain penicillin that obligate the excretion of cations like sodium. Impaired sodium reabsorption is also seen during the osmotic diuresis in certain form of the chronic renal disease. Now we'll see what is instant. So the reduced renal function may also reduce from the renal parenchymal injury. Such an injury may arise from the glomerular, it could be from the vascular and tubulointerstitial disorder, and it may represent either primary kidney disease or renal effects of underlying systemic disease like systemic lupus erythematosus, glomerular and the vascular disease. The GFR may be abruptly reduced by acute glomerulonephritis. So the patient may present with the constellation of hypertension, edema, azotemia, hematuria known as acute nephritic syndrome. The hypertension and edema results from impaired excretion of salt and water. Although the history of previous sore throat and the streptococcal infection may provide diagnostic clues, the urine analysis is particularly valuable. The urine may be grossly bloody and the tea color, and urinary sediment contains the RBCs and often RBC cast. The post-streptococcal glomerulonephritis, it presents with AKI, oliguria, crescentic glomerulonephritis, rapidly progressive glomerulonephritis, such as antiglomerular basement membrane disease, and ANCA, that is anti-neutrophilic cytoplasmic antibody-associated glomerulonephritis, can also cause AKI. Similar findings are frequent in patients with other primary nephritic disorder, such as systemic lupus erythematosus and bacterial endocarditis. Disease affecting either main renal arteries or their branches may precipitate AKI. Renal artery occlusion by acute thrombosis and thromboembolism typically only cause AKI, and if it is bilateral or involves a solitary functioning kidney. This process may be silent or may produce flank pain, hematuria, particularly if abrupt renal infarction. Fever, moderate leukocytosis, elevated serum level of lactate dehydrogenase should raise the suspicion of infarction. Renal arterial thromboembolism occurs only in the setting of acute myocardial infarction, atrial fibrillation, bacterial endocarditis, cardiac valvular disease, or hypercoagulable disorder. Acute renal vein thrombosis seldom causes renal failure unless both kidneys are simultaneously occluded. Acute flank pain and hematuria are clinical hallmarks. Renal venous obstruction may occur as a complication of nephrotic syndrome or renal cell carcinoma. Now, the microscopic occlusion of smaller veins vessel occur in variety of disorder, including atheroembolic renal disease, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, scleroderma, postpartum kidney injuries, and malignant hypertension. Scleroderma or malignant hypertension may appear as AKI, and the urine sediment is usually acellular or and black. Vasculitis produces AKI either through direct involvement of renal arterial system or by inducing glomerulonephritis. Microscopic polyarteritis and granulomatosis with polyangiitis, formerly known as Leschner's granulomatosis, may present with the evident renal parenchymal disease and suggested by urinary abnormalities such as microscopic hematuria, RBC cast, and proteinuria. Patient may require ICU care when there is multi-organ involvement, such as pulmonary disease that occurs with granulomatosis with polyangiitis. Fulminant presentation with severe hypoxemia and pulmonary hemorrhage may be accompanied by rapidly progressive renal dysfunction. In these cases, glomerular involvement may range from the focal and segmental necrotizing glomerulonephritis to crescentric glomerulonephritis. Now, the next is tubular interstitial disease, acute tubular necrosis, and acute interstitial nephritis. Acute tubular necrosis, it is a syndrome that may result from renal ischemia and exposure to nephrotoxin, such as aminoglycoside antibiotic, radiocontrast agent, heavy metals, and myopia. The pathophysiology of AKI and ATN has been attributed to three processes. That is obstruction of tubular lumen by sloughed epithelial cell and cellular debris, back leak of filtered waste into circulation through disrupted tubular epithelium, and sustained reduction in the GFR following inciting stimulus. Now next we'll see what is tubuloglomerular feedback. Severe cortical vasoconstriction has been noted early in the course of AT, which is likely mediated by endothelial cell injury and locally acting vasoconstrictors such as endothelium. Afferent arterial vasoconstriction has been described. In ATN, impaired proximal solid reabsorption increases the distal chloride delivery to macula densa, which in turn mediate afferent vasoconstriction via secretion of adenosine. So this process is termed as tubuloglomerular feedback. The modest hypoperfusion leads to prerenal azotemia, characterized by the modest reduction in the urine output and GFR and preservation of the tubular function, which is rapidly reversible. However, a more critical decrease of renal perfusion leads to medullary hypoperfusion, ischemic ATN, with greater reduction in the GFR, abnormalities of tubular function, and often histological evidence of tissue injury. So because recovery depends on cellular regeneration, reversal of ATN is much slower than prerenal azotemia. The most extreme form of hypoperfusion injury is cortical ischemia associated with either patchy or diffuse cortical necrosis, typically manifesting the most severe reduction in GFR and in much less certain prognosis for recovery of renal function. The medullary thick ascending limb segment of the loop of Henle is particularly vulnerable to ischemic and nephrotoxic insult. The immune system plays a critical role in the pathogenesis of ATN, that is through recruitment of various inflammatory cells, cytokine release, complement activation, induction of tubular cell apoptosis. The protein neutrophil gelatin is associated lipocalin. It is a regulatory molecule which is expressed in the kidney. NGAL is released early in the course of ischemic ATN and appear to attenuate tubular cell injury and apoptosis. History of exposure to predisposing factors such as prolonged ischemia and toxin can be elicited in approximately 80% of patients with the AT. Most individuals with this syndrome have classical finding of sloughed renal tubular epithelial cell cast or muddy brown granular cast in the urinary setting. These findings are not seen in prerenal azotemia. In addition, calculating fractional excretion of filtered sodium may enable the clinician to differentiate between the ATN and prerenal azotemia. The FENA expresses the urinary sodium excretion as a percentage of filter. It provides the more precise representation of tubular sodium avidity than urinary sodium concentration because it is not influenced by changes in the urinary concentration or flow rate. FENA is very low in prerenal azotemia as a result of active sodium reabsorption by renal tubule. When frank tubular damage has occurred, as in ATM, the tubules can no longer reclaim sodium effectively, and the FENA is generally high. The urinary concentration is also impaired in tubular necrosis. As a result, urinary osmolarity approximate to that of the plasma, and the ratio of BUN to creatinine is less than 20. Now we'll see what is acute interstitial nephritis. The term acute interstitial nephritis is characterized by the acute inflammation of the renal interstitium and tube. Depending on the specific nature of the condition, the inflammatory infiltrate may consist of combination of neutrophils, eosinophils, lymphocytes, and plasmids. Most cases of acute interstitial nephritis represents allergic reaction with eosinophilia, skin eruption, and usually induced by medication. So interstitial disease can also occur because of infectious agent, including Brucella, Leptospira, Legionella, Toxoplasma, and Epstein-Barr disease. These disorders are to be distinguished from the familiar entity acute pyelonephritis. Acute pyelonephritis, it is a superacute disease of the tubular interstitium, usually caused by bacterial infection ascending from urinary bladder. So the acute pyelonephritis rarely causes renal dysfunction. Now we'll see the last type of the AKI, that is post-renal azotemia. The term post-renal azotemia or obstructive uropathy refers to azotemia caused by obstruction of urinary flow from the kidneys. So the renal outflow obstruction has many causes, and the most common are prostatic enlargement, nephrolithiasis, and genitourinary tumor. For obstruction to produce azotemia, both kidneys must be involved because one normally functioning kidney is sufficient to maintain near normal GFR. Now, the causes are ischemic tubular injury, sepsis, glomerulonephritis, interstitial nephritis, drugs and toxins, diseases such as rhabdomyolysis, tumor lysis syndrome, multiple myeloma, and microangiopathies. Now, what is the post-renal failure? The clinical history often helps with the diagnosis of obstructive uropathy. Prior kidney stone should raise the suspicion for obstruction, particularly in the setting of symptoms of renal colic. AKI in an elderly man who has been experiencing urinary hesitancy most likely represent obstruction of the bladder outlet by enlarged prostate. A history of genitourinary malignancy in an azotemic patient also make obstruction the most likely diagnosis. AKI in setting of painless gross hematuria and history of NSAID should prompt the suspicion of papillary necrosis, a condition in which slough of renal papilla can cause bilateral renal ureter obstruction. When urine output declines precipitously or ceases entirely, that is anuria, it causes the complete obstruction of urinary, then the complete obstruction of urinary tract must be ruled out. Such an obstruction is likely to be located at bladder outlet. If patient has only one kidney, that is due to a previous nephrectomy, unilateral renal disease, and congenital solitary kidney. However, anuria may occur with the unilateral ureter obstruction, even though the complete obstruction is the common cause of anuria. So the partial obstruction is not always associated with decline in the urinary output. With partial obstruction, damage to the kidney may impair ability to concentrate urine, resulting into the polyuric state. In patient with the complete unilateral obstruction of ureter, the contralateral kidney often sustain normal urine output. So obstructive uropathy is associated with the other defect of distal neuron, including reduced hydrogen ion and potassium secretion, as well as impaired urinary concentration. Consequently, the patient, particularly if there is prolonged high-grade obstruction, may present with hyperkalemia, hyperchloremic metabolic acidosis, hypernatremia, or combination of all of the three. As discussed, the urological causes of AKI are the best diagnosed by renal imaging techniques. The urine chemistry is generally of little help in diagnosing obstructive uropathy. Likewise, the urine analysis provide only indirect evidence of possible cause of AKI. Hematuria reflects the trauma to urinary epithelium caused by obstructing lesion. Crystals in the urine sediment may suggest kidney stone. Now, the causes of obstructive uropathy is extrarenal or intrarenal obstruction, urinary stone, urethral stricture, ureteric bladder tumors, and benign prostatic hypertrophy. Thank you.